We'll explore how access to healthcare is both a social determinant of health and also it is impacted by other social determinants. Our ultimate goal of this series is to stimulate action that leads to systems transformation and ultimately greater health equity. I would like to thank Baycare Health Systems for their generous support of this initiative. And I would also like to thank all of you for making the time to be with us today. During today's session, all participants and microphones will be muted. We will have some time to address questions at the end of the session. And if you have a question for a presenter, please use the Q&A function at the bottom of your screen, which will be monitored by Allison Rapp, our Special Projects Manager. Please feel free to use the chat function for general questions or comments. And in addition, you will be receiving a list of resources, copies of the slides, and a link to this recording following the session. We have two presenters today who will provide their perspectives on the crucial role access to healthcare plays in reducing health disparities and moving us toward equity. Our first speaker will be Dr. Zachary Pruitt, Assistant Professor at the University of South Florida College of Public Health. He was recently recognized as an American College of Healthcare Executives Fellow. Dr. Pruitt teaches undergraduate and graduate courses, including Understanding U.S. Healthcare, Health Services Management, Quality Management, Strategic Planning and Healthcare Marketing, and the Advanced Seminar in Healthcare Management. He also teaches health systems curricula for the USF Morsani College of Medicine. Dr. Pruitt recently co-authored a textbook, Healthcare Quality and Management, a Case Study Approach. His research interests include the integration of medical and social care for vulnerable populations by addressing social determinants of health. Prior to academics, Dr. Pruitt directed Medicaid operations and regulatory affairs for a small Florida health plan and managed policy and compliance projects for a large publicly traded managed care organization. Dr. Pruitt currently serves as president of the Western Florida chapter of the American College of Healthcare Executives and of the Commission on Accreditation of Healthcare Management Education. Our second speaker will be Scott Darius, Executive Director of Florida Voices for Health. Florida Voices for Health is a coalition of community organizations, businesses, and individuals working to create a healthcare system that works for every Floridian by empowering them through education, advocacy, and action. The partners work together to bring the latest resources and information to our communities, and they also make sure that the stories and the interests of hardworking, low and moderate income Floridians are represented in the healthcare reform debate. Scott began his career in health advocacy in 2012 when he joined Florida Chain as a volunteer intern, helping with various advocacy projects and research assignments. And in 2014, he joined Florida Chain staff as the digital and community organizer and became an Affordable Care Act navigator. He eventually became the advocacy director, where he helped coordinate a statewide campaign for Medicaid expansion. Scott has always had a passion for healthcare issues and hopes to be engaged in this process until quality, affordable healthcare is truly available for everyone. Scott completed his bachelor's degree at the University of Florida with a major in political science in 2010 and graduated from the University of Florida College of Law in 2013. As a law student, he focused on health policy, insurance law, social justice issues. He is based in Miami, Florida. Scott believes that how you arrive at the outcome is just as important as the outcome itself. Florida Voices for Health, whether dealing with coalition partners or people who disagree, tries to approach the work with humility and grace. I want to thank both of you for being here today. So Dr. Pruitt, I will turn it over to you.
Great. Thank you very much for that introduction, Teresa. It's my pleasure to be here with you today and to join Scott Darius. Scott and I know each other from various things. I didn't realize he was so young. I'm now doing the math here. How have you accomplished so much in so much little time? I want to know. But it is my pleasure to be here. I appreciate Allison Rapp asking me. We work together at the College of Public Health, and I enjoy teaching very much, and I know she does too, so it's a pleasure to be here. Let's see here. I'm sharing my screen. Should be good. So, social determinants of health. If you are in the College of Public Health, you've been saying this word salad for quite a while. But other people don't necessarily know what social determinants of health are, nor do they know the consequences of inequitable access to healthcare. So it's my pleasure to tell you a little bit about both of these concepts and how they're related to health outcomes. This is a topic that we work on very hard in the college, and this is my area of research. As Teresa mentioned, I do focus on how we can integrate social determinants of health into the healthcare system. And you may not be surprised to learn that we don't do a very good job yet, but we are aspirational and we hope to do a better job. So the objectives for this presentation are, I want to disconnect social determinants of health, social risks, and health inequities as concepts, review the consequences of social risks in healthcare access and outcomes, and I'll talk about some of the most important social risks, including poverty and unemployment, transportation barriers, lack of education, food insecurity, and social isolation. And then, perhaps more in a positive note, talk about how medical care and public health and social care can integrate for better healthcare access and better health equity. So first, let's start with social determinants of health. Healthy People 2030 organizes social determinants of health into 5 domains, although we could organize it in many different ways. This is a great framework for it. So economic stability, education access and quality, healthcare access and quality, neighborhood and the built environment, and social and community context. What this is saying is that all the things outside of healthcare actually can influence health access and outcomes. So it's perhaps an old allegory or story, and then maybe you've heard it in before, but we like to say in the College Public Health, the idea of the upstream and downstream story. So imagine someone in public health was standing with someone in medical care and aside a river that's flowing downstream. And in that river, they see someone who is drowning. They both jump in, they save this person, and they're just gasping for air. And of course, the medical professional says, "Yes, I saved him." And the public health person says, "Okay, but wait, there's another person." And they jump in, they try to save that person from floating downstream, from drowning. And they pull him out. And again, they congratulate themselves. And then a third person comes floating down the stream, and the medical personnel jump in to save them. And the public health person runs upstream. And the medical personnel says, "Where are you going?" And the public health person says, "I'm going to see what's causing them to fall into the stream in the first place." So what we're trying to do in public health and many concepts of social care is to move upstream to address these social determinants of health. Now, related to that, or really something, maybe it's just a semantic issue, but these social risks are something that we work to identify because we know that they're related to poor health outcomes. Social risks go within, or it can be connected to social determinants of health, but these are the things that cause bad health: poverty, unemployment, transportation barriers, housing instability, lack of education, food insecurity, social isolation, and then, of course, racism and bias. At the individual level, all these things contribute to poor health outcomes. At the community level, they lead to health inequity amongst the groups. So we want to watch out for these social risks. So again, the patient level, all these things lead to poor health outcomes. This is another way to look at it. So here's all the social determinants of health on the top: economic stability, neighborhood and physical environment, et cetera. And then the issues, the social risks are below that. And what I want you to notice how racism and discrimination is pervasive through all of these contexts and social determinants of health, leading to poor health outcomes on the bottom. Mortality, meaning dead or not dead, morbidity, sickness, right? Life expectancy, higher health care expenditures, health status, and functional limitations. All of these things are bad health outcomes for and related to what we've said upstream factors or social determinants of health. Again, groups of people is health inequities. And so we define equity in health as the absence of systematic disparities in health, right? These are systematic things. These are in the major social determinants of health between groups with different levels of underlying social advantage or disadvantage, that is wealth, power, or prestige. So those systematic disparities can be things like racism and discrimination, but it can also be social risks like transportation barriers, lack of access to, generational wealth, poor structures of the built environment. So inequities in health systematically put groups of people who are already socially disadvantaged, right? So by the virtue of being poor, maybe female, members of a disenfranchised racial, ethnic, religious group, and it puts them at further disadvantage with respect to their health, right? These keys systematically, it's what we're facing today and what's been highlighted, and I'm sure in the other presentations in this series, is the idea that these biases, that racism in general, and the things that come from that are systematic. They're not by accident, and it's definitely not by birth. You can see this is the Kaiser Family Foundation taking a look at racial disparities and health outcomes. And they just took a group of measures of healthiness, right, and compared to whites. So this is the Black people on the far left, Hispanics, Asians, so on. And they just said, how many of those measures, like mortality or lifespan or those sorts of things, are worse or same or better than whites? As you can see, the majority of those measures for Black populations are worse. Hispanic, it's a little bit more than half. So these are systematic issues related to health outcomes. So let's talk about the title of the presentation is about the consequences and social barriers to access to healthcare. I want to walk through each of these. There's a substantial amount of research on these topics that show that there's poor health access and poor health outcomes related to all these issues, such as education, poverty, unemployment, food insecurity, social isolation, and then transportation. I put a bus there because many people in disadvantaged groups take the bus. But of course, rurality, living out in the country, is also a challenge where their health access is a distance related issue. So let's start with poverty and unemployment. Let's group them together. In this country, those are interrelated. We don't have a incredibly robust unemployment system, as we've seen during the pandemic. It's a lot of challenges with that, and likely also systematic in challenging the access. Certain states have better access to unemployment benefits. And then, of course, poverty is related to all of those things as well. So access to work is related to poverty, and you see how it can go back and forth. Poverty can be related to unemployment. But both of those things in this country are related to uninsurance. No health insurance is likely because of poverty and unemployment. We get our health insurance typically through the job at work, but although Medicaid access for the very poor in this state, as Scott can speak to, we did not expand Medicaid, so access to that is difficult. But for many near poor, even buying subsidized insurance through Obamacare is an impossibility. So again, poverty and unemployment are linked. Now, the Affordable Care Act, and through work of people like Scott Darius and other navigators, and of course the Obama administration for passing the law, made huge inroads into covering more and more people with health insurance. It is so critically important, and I'll get to that in a little bit. But as you can see, as the ACA was implemented, the number of uninsured rates among non-elderly declined very quickly. Love it. 13.5%, 10.9, and so on. Now, we have seen a slight increase during the Trump administration, but it wasn't as bad as we thought. Now, I feared the worst, thinking that it really required some of the mechanisms of Obamacare for the health insurance exchange to work, without going into too much detail. But we were surprised. Actually, people now that they had health insurance, wanted to keep it through the health insurance exchange. And there's some erosion, and that's a problem. And I think that the Biden administration has already committed to making sure that those increase number of people getting insurance through opening up the enrollment times and other funding opportunities. So this is really good. This is good. Of course, Florida still has uninsured rates, and a lot of this has to do with the I would view the failure to expand Medicaid, but there are other issues, of course. 12+% for Florida is not great. So we have work to do. The reasons that people are uninsured are the coverage is not affordable. If anybody has bought insurance, even through the Obamacare with the subsidies that it provides, it's difficult. Not eligible for coverage, there's something called the near poor. I was mentioning it earlier, but the idea that they don't qualify for Medicaid, but they don't make enough really to afford health insurance, even with subsidies. A lot of people don't need or don't think they need or want health insurance, especially what we call the young vulnerables, my college students, perhaps. They're like, listen, do I want to buy something that I'm not going to use because I'm young and healthy? Of course, being more older in age and have a grown-up perspective on it, we know that insurance protects against risk and things that could happen. And so we certainly, as a older adult, think it's more important, but those can be challenges. And so there's still some small things that we think are reasons for it, but mostly it's about the coverage not being affordable. So who are the uninsured? You'd think that it was the people that are just, not working, or perhaps the homeless, or the, disadvantaged in some ways. But a lot of times it's somebody that's working in their household, right? One or more full-time workers generally, right? So it's your service staff. It's waiters, waitresses, somebody who works, in the service industry is a great example. Family income is pretty well distributed through all those. You'd be surprised at the number of people who have family incomes below 100% that are not covered. But, in Florida, it's very difficult if you're a childless adult to get insurance. You can't get Medicaid insurance. So this is a challenge. Race and ethnicity, mostly white folks, although a larger proportion of Hispanics than the population at large. And so that's concerning. And this is a really important slide. What is the impact of no insurance? It's hard to conceptualize when, I know I have insurance. I feel comfortable with it. I'm glad that I have health insurance, but what does it mean when you don't? And generally, it's really important to understand these issues. 41.5% of the uninsured did not see a doctor or a healthcare professional. Usually it's fine if they're healthy, right? But think about the example of finding a breast lump, right? Not going to the doctor because of that becomes a real scary proposition. Not wanting to go because of what it would cost is a challenge. No usual source of care. That's a fancy way of saying they don't have a regular doctor. They postpone seeking care due to cost. went without needed care or delayed filling or did not get a prescription filled because of cost. So these can really lead to dramatic uh, health problems. So they took a look at, okay, how do we know the impact of health insurance? Now, as a health services researcher, this experiment really is exciting to me. The Oregon health insurance experiment is actually kind of famous because of how it came about. Oregon wanted to, before Obamacare, expand health insurance to expand Medicaid, but they couldn't afford to do it for the whole uninsured, poor, or in poverty population. So what they created was a lottery system, and in and of itself created a study. Because they randomly assigned who got health insurance, they could then study the group between who got it. Um, they called that the control mean, that's in dark blue, and those who got Medicaid. And they asked, so how are you feeling? Are you feeling healthy? And there's a significant difference between having good health for those who had the health insurance, right? No depression. These are random assignments. And so in some ways, you can say there's a causal link, right, between depression and not having health insurance. It would bum me out, certainly, to not have health insurance. So that's easy to imagine. But this is a fascinating study to show the value of health insurance in people's lives. And perhaps even more importantly, people are accessing the care. Um, the probability of hospital admission goes up. I think what happens is they have a doctor, they have a need. The doctor says go to the hospital, and they're able to access that care. They go through the hospital, through the doctor into the hospital more often than they do through the emergency department. That is, the gap is bigger for going to the doctor than not going going to the emergency room. So that's really promising. It shows that just having health insurance makes people get the proper care. That's the assumption being made here, and it's really important. And perhaps even more important, health insurance leads to improved lifespan. It decreases deaths, which is great. So in Massachusetts, which of course you may know was Massachusetts Health Exchange, was the model for Obamacare. The idea of creating a health insurance exchange for private companies to offer health insurance to the population, to the citizens. And Massachusetts was one of the model and implemented it before ACA. So they were able to look at a population level, the relationship between mortality or death and having the health insurance. And what they found was that it saved thousands of lives by having health insurance, likely through the mechanisms described above, being able to access care. So again, mortality related to poverty and unemployment. You can see how this mechanism might work. So it's a huge deal, the work that people are doing to try to expand Medicaid, because these are lives at stake. So let's talk about transportation barriers. My car works. I'm happy that it does. I can get to the doctor. I rarely have to think about fixing my car or doing those things as a fortunate individual. But rural residents and those in low socioeconomic status have transportation barriers. It's just a fact. And they have trouble accessing it and getting to the doctor because of this. The consequences of transportation barriers is worse health outcomes across a multitude of disease states. The studies have looked at chronic disease, worse. Type 2 diabetes, worse. HIV infection, worse. Many types of cancers are worse, just because they can't get to the doctor and the stress related to that. They miss appointments, for example, and all those things, right? Amongst the low SES, or social economic status, which is a broad term that includes poverty, more emergency department visits, missed appointments, delayed medication fills, poor adherence to medication. This is all due to transportation. Fantastic work being done by researchers. Let's talk about lack of education. And that means two things, really. So misunderstanding of the health system and behaviors related to healthcare access. Certainly misunderstanding the health system is related to lack of education. I think the ability to learn or to have confidence to learn is really important. Our healthcare system is a mess. It's hard to understand. I imagine it would be hard to understand in any country, but we make it work by having a hodgepodge of different healthcare systems and eligibility criteria and who pays the bill. It's just makes my head spin. And I went to school for a long time to understand this stuff. Parents whose children were covered by Medicaid believed pediatric emergency department provided better same-day access to healthcare than an outpatient clinic during the daytime hours. That's hard to believe. Who wants to go sit in the emergency department? But for many people with low acuity pediatric problems for their kids, thought that the emergency department would be a better place to go. And of course, education is related to health behaviors. I think we've seen that. And a lot of that is sort of what we call self-efficacy, the idea that you have confidence that you can improve your health through certain behaviors, that it does matter, is really important. But better educated people access primary and secondary preventive care. We go to the doctor. We have diabetes, so we keep our hemoglobin A1C controlled. We know that the doctor can provide us with diagnosis and certain behaviors that'll, prevent worse health outcomes in the end. And so when we have barriers related to transportation, of accessing to this health services, and then we make it worse by having limitations on access to healthcare and to quality to education and quality education, it makes it even worse. So you can see how racial disparities could exist in a country that has systematic structural disparities amongst ethnicities and races. An education relationship to the lack of healthcare access found in hundreds of studies. Hundreds. It's hard to, I'll have a slide here with just a few of them at the end, but education may have only a modest role on explaining the disparities to access, but it may be a causal factor for other issues related to social determinants of health, again, such as employment and poverty. So, it's an advanced concept that, providing education and a quality education can lift up people out of poverty, but putting barriers to access to care makes things even worse. Food insecurity is probably the highest, and you can really imagine how this would be a problem for healthcare access, because people forego healthcare in order to buy food. If they don't have access to regular food or consistent access to food, it's insecure where they're going to get their next meal, they'll certainly make that trade-off. Food insecurity and access to healthcare, they found that patients insured by Medicaid, that is someone with very low levels of poverty, very low or high levels of poverty, low income. It's the federal poverty level. Sorry for that phrase there. That just means that very poor. Reported that food insecurity was highly associated with cost-related underuse of medications. Well, I'm not sure if I'm going to eat, so I'm just going to split this little pill in half and take half now and then half tomorrow, and maybe that'll work. That, of course, from a pharmacological standpoint, does not work, right? Once you get below a certain dosage, it won't actually activate any drug. It's not doing half as much as doing zero. And so when people skip like this, it really has huge consequences on their health. Food insecurity relates to low adherence to HIV antiretrovirals. That's surprising, right? You're not going to, because you don't have consistent access to food, you're not going to take these drugs that will keep your immune system operating as it should. Mediated by a lack of personal resources and interpersonal support associated with poverty. That is, it's not just food insecurity, it's things of having resources, poverty, and being lonely, not knowing who to turn to, not having personal resources, social capital, if you will. It really impacts food insecurity and access to these HIV drugs, which leads many researchers, like my colleagues at the USF College of Public Health, to say, okay, maybe we should research how to keep people engaged socially when they're taking these HIV drugs. And of course, right to it, social isolation, the loneliness There is some mixed evidence on this, but I do think we agree that being socially isolated or lonely really impacts health. But specifically regarding health access, they've done some studies finding that social isolation and access are related. Now, the mixed is something that you probably will nod your heads at home about. Social isolation is negatively related to follow-up care after an emergency department discharge, right? So if you're lonely and you get sent home and you're feeling sick, they are less likely, those with issues, to go to the emergency department. However, chronic loneliness among older adults is actually associated with increased use of physician care. I smile a little bit because you can imagine the elderly going to the doctor just for some company or to see the staff and to talk. And I think that's understandable that would be related. But that's probably a good thing in many ways. We can find time in our health system for those things, but we'd prefer not. We'd prefer not. So that leads me to this: addressing social risks through medical care. So, like I said, if the old grandfather is going to the doctor just to get some company, isn't there a better way to do that? The medical system could sense, all right, this man is lonely. And so he's taking up medical care resources, expensive, restricted in access, all those consequences, and saying, how do we improve his life through non-medical care interventions and then improve his health outcomes? Really important to think about it. Now, I want to highlight this one from Ronald Wyatt, MD, MHA, who was at one time at the Institute for Healthcare Improvement when he wrote this article for JAMA, essentially suggesting that there's a role to be played in racial bias in healthcare and health challenges and opportunities. He was basically saying, look, the healthcare system cannot eliminate these racial and ethnic disparities in health. Healthcare professionals need to collaborate with other parts of society to increase awareness about health implications of social policy in domains far removed from traditional medical and public health interventions. Now, that is wise and smart. That is on point to what we're talking about today, the opportunity for the medical care system to integrate social care and public health into the work that they do. But there's one more thing I want to mention. When Dr. Wyatt, submitted this article to JAMA, he called it racism in healthcare and health challenges and opportunities. But the editor at JAMA asked him to change that title because it was too harsh for JAMA to hear, for the readerships. And he has to sell magazines, essentially. He has to sell journals. And Dr. Wyatt agreed to it. But in the past month or so, it's come to light that not everyone believes that racism exists amongst doctors. In fact, on a podcast a few months back, the JAMA co-editor said that he didn't think racism existed amongst doctors. He didn't think, I say it again, he didn't think that racism existed amongst doctors, not some doctors, but all doctors, like doctors as a profession. And so that really caused an outrage. And he later resigned from JAMA, this person who said it. And then Dr. Wyatt wrote a piece in the Washington Post basically saying, look, they asked me to change this, and we've come a long way. This is 6 years here where we're realizing that it's race is a systemic issues in our healthcare system and more broadly throughout the society that's causing this. So the health system and other sectors should take a look at itself about how to improve these factors, improve the system, the structures to improve health equity. And that's just what the National Academies of Science, Engineering, and Medicine are saying. We need to build intersectoral partnerships amongst social care and public health to improve health outcomes. The future of public health in the 21st century is more integrated amongst these sectors. We, for too long, have been in this country separating housing, food, social care, social, connection from how we think about health and healthcare. And we spend the most on healthcare out of any country in the world. US is 1.5 times more than the nearest country in spending on healthcare, which, considering that we have many health outcomes that are like 30th, 36th in the world, such as maternal mortality and infant mortality and lifespan, these mean that we have less value. When you take a look at the spending on medical care and social care combined, the gap between the spending in the United States and the next nearest country is still more, but it's not as wide. And that's because Nordic countries, European countries, and many other sophisticated economies include social care as a upstream factor, an upstream investment in people's healthcare. That means it's a higher return on investment when they're providing housing, when they're making sure that people have food available to them, right? These public health and social care issues. And so the light bulb is going on for national academies, saying that we need to do a better job of integrating. Now, that could mean that health insurance companies start buying housing units so that they prevent hospitalization. And in fact, we're seeing that. It could mean that doctors and nurses collaborate with other interprofessional groups or professions to coordinate medical care and social care, such as health advocates or patient navigators or community health workers that are doing just that. So we have a lot of work to do in this area to achieve health equity, but we can only do it from the medical care's perspective if we collaborate with professionals from the other sectors. So let's talk about it. What are they doing now to integrate social determinants of health into the clinical setting? I do want to talk about some examples of primary care in detail, but you should know that even specialists like people that address physicians who address diabetes are focusing on this issue. The inpatient, of course, it's happening because of Medicare's decision not to pay hospitals for readmissions. And really, the biggest impact for readmissions is these social determinants of health. You discharge someone from your hospital, they go home, nobody's there to support them. They go home, no food's in the fridge. They go home, they can't do a follow-up because they don't have transportation to the doctor, right? So all these issues are coming to light, and never in the past, hospitals were throwing up their hands saying, look, how can we be held responsible for all these things outside of the medical care system? We're the best healthcare system in the world. We have the best doctors, the best nurses, the best technology. And now you're penalizing us because we can't keep food in the fridge? And Medicare said, that's right, we are. So they have a sort of a penalty system where they won't pay for these inpatient readmissions because of that. Again, there's so many wonderful health professional team models, health advocates, navigators, community health workers, community liaisons. These are all terms for people whose job it is to coordinate care within the medical care system with the external sectors or with these social care and public health systems. So let's talk about primary care a little bit more closely. If you're in this business in any capacity, you probably have heard of community health clinics. And those are really important local clinics that handle care for people with Medicaid, people with no insurance, immigrants, migrant workers. And so they have a tool that they use for screening for social determinants of health. It's called PROPARE. It's a terrible acronym, but I guess PROPARE sounds good. Protocol for responding to and assessing patients' assets, risks, and experiences. Really, it just takes all the categories we talked about, the social determinants of health, and says in a form, hey, do you have issues with it? You have social risks associated with this, right? What's your housing status like? Or do you feel safe in your neighborhood? Do you have risk for social and domestic violence, right? So it's just a standardized instrument that they use at these clinics and many outpatient organizations across the country to identify these social care needs. And it integrates with EMR, right? So this is a common tool, instrument for screening for social determinants of health. And it really flows right into, this is an example of EMR called eClinical Works, which is a common one for outpatient or for doctors' offices in general. And so that's very helpful for the process, because you can imagine I screen for it. They have social determinants of health. They have social risks associated with, let's say, food. They're a diabetic. They get referred to the food pantry. They come back to the doctor's office, who says, I noticed that you were referred to the pantry. Did you get that food? And how's your diabetes doing? Is your hemoglobin A1C better controlled because of that? Are you taking your medicines because of that? So the feedback loop is enabled by integrating with technology. So at the outpatient or the doctor's office level, there are so many options, and it depends on where you work and what you do and how it's organized of how you do it. You could have the patient complete that screening. You could have a medical assistant do it when they put the patient in the room. They could do it after the clinical visit. The doctor saw you today, just want to check on all the issues. You could do a clinical visit with the physician, or the nurse practitioner could say, during the visit, they're doing all the history and physical, and they could do it. Many organizations have navigators already, and it's usually focused, because of the funding through Obamacare, with getting access to health insurance. As we mentioned above, super important for access to healthcare. But it's often the case that those individuals also work with social care and are referring to those issues I described above. And so these individuals can make those referrals and make that screening and those referrals. And you can also have call centers. You can imagine how you could centralize it, saying, if you have issues, call this number. In a call center, having medical assistants screen for it every time you talk to a patient is a really good idea across the board. And many communities have online resource listening. This is a nonprofit called Aunt Bertha. Aunt Bertha is a database of social care organizations that's updated by those organizations and maintained by other social organizations. You can pay for it in a certain way to allow you to send leads or referrals out, but it's a free listing, which is really helpful for people in the Tampa Bay area, which has Aunt Bertha. I think it's a Texas company, nonprofit, but it's all over the country that this is available. But there are others, and I think the Tampa Crisis Hotline has the 211. They have a great listing, and there are many other ways. A lot of organizations will just have an Excel spreadsheet or whatever to track it. But what point is oftentimes doctors or medical establishment doesn't know where to go to get these resources. And so there are these available. So with that, I want to leave you with some time. We have about 10 minutes or so to ask questions. I would be happy to answer those. I'm going to stop sharing just so you can see me here a little bit. Okay, let's see. In the chat.
Great. So we do have a question. I am going to read it. Historically, healthcare coverage decisions have been made based upon just the direct healthcare costs rather than the overall costs to society. For example, difficulty in staying employed, costs on the justice system. Is there anyone looking at the societal costs of undercoverage and lack of prevention as part of determining health policy, then measuring the impact of programs, interventions based on societal impact, both financial and non-financial?
That's beautiful. And it's a big question that you're asking, but it's the question to be asked. And so, like many things in science, you really can't ask that big of a question, right? I mean, you can spend a career asking the constellation of those questions. And so the short answer, of course, is yes. The challenge with that, the evidence is mixed. And it's because, remember the example I gave above where social isolation was related to both increase and decrease use of of healthcare services, it's because it gets messy, right? And on insurance, for example, when you give people insurance, they use healthcare more, which is really a good thing. And so then it takes, you got to sort of, okay, what's the cost of insurance? What's the cost of more hospitalizations, and is that worth it? So you gotta, you've got to be a health economist to assign value, cost effectiveness value to those outcomes. So it's tricky, but yes, of course they've done that. But at a small level, my colleagues and I did some research that looked at the relationship of social needs to overall healthcare costs. It compared those individuals who got their social needs met to those who did not. So we had a big pool of people who all had social risks. Some of them got their risks, their needs met, and some did not. So we compared them to their overall healthcare costs, right? So we had their claims, all the money that they were spent in healthcare, hospitals, doctors, pharmacy. What we found is a significant savings for those who got their social care needs, over $2,400 a year in additional savings for the group who got their needs met. Yeah, it's a big deal. And health insurance companies and Medicare want to know that information. But again, that's just one sliver of the big question that they're asking, which is the most important question we have. In terms of the value. But you have to remember, going back to, what Dr. Wyatt was saying, a lot of these things are structural. A lot of these things are, in my opinion, and I'm sure there's lots of debate about critical race theory, and we could get into the morass of that debate, but a lot of these issues are in these structural differences between the haves and the have-nots are at a societal level purposeful. And what Dr. Wyatt was trying to say is that those are caused by racism in some form or another. And I know this is controversial, but what I'm saying is, just because you provide evidence of the value of providing access to care, access to education, reducing poverty, it doesn't mean that the will be there. So we have to try other effects. I'm happy to contribute as a scientist to that, but we need Scott Darius to communicate to people's values and to to help them vote in that way. So great question. Wow.
I want to encourage anyone that they can absolutely add questions to either the chat or the Q&A for the next few moments. While there are a couple of additional questions, I will share the next one. Is why do you think so many MDs, DOs are or were in denial about racial bias? That is quite shocking to hear, and cross-cultural competence has helped some.
Well, in some ways, in defense of them, it is understandable. It's like, like my heart's good, and I remember when Obama was elected, I was like, man, we are post-racial. This is awesome. We've captured it. I wrote a lecture that was, basically saying that racism was not at least as public as it used to be, and those sorts of things. And so I was so wrong because, so I didn't think that we were racist. I don't experience it. And so I wrote a lecture that was like, it's improved. And then we get to this environment we are in today. And I gave my TA the lecture to give, and I sat in the audience. She gave this lecture that had basically the statement of we're we're post-racial. Here we are, and the whole audience of everyone basically, but especially this Black woman sitting in front of me gave this look like, "Are you kidding me?" And so I had to admit, "Okay, oh wait, I wrote that. Sorry." And so I will admit to some, just we need to just be told that this still exists, and so people didn't just one doctor. So it's just one representative of one, and the editors, and just the insensitivities of the lived experience of other people. And so that's true of everyone. That's true of everyone. So we all have to get there. So my wife's a physician. So you guys report back that I defended physicians.
had muted and I'm unmuting myself now. I have more of a comment to share. Leah Gonzalez with Baycare
I know Leah. Hi.
sharing,
How are you?
and I see it's only being shared with the panelists. I believe that, and she says hi. So depending on how you're sharing, if you're looking to share through the chat, make sure that you are selecting panelists if you wanted to go just to the panelists, or panelists and attendees. Anyway, Leah is sharing that Baycare is working with Aunt Bertha and will be soon launching the community-facing site for organizations and community members to utilize. Social service providers that may be interested in making sure that their information is included on the site, or if there's an organization interested in utilizing it for clients and patients, she has asked that you contact her at leah.gonzalez@baycare.org, and all of anyone that needs to get in touch with her following this, I would be happy to share that info as well. And the last thing that I will bring up is another, it seems actually more of a comment, but Dave Rogoff shares, having been in policy change prior to retirement, the conservative decision makers need to be shown cost impact. Can't prove investment worth it if just direct health impact. So if you want to address that.
Yeah, I mean, same point, right?
Yeah.
Like, so what? Show me that it's worth it. If they don't see it, they don't understand it, they don't believe it, then they'll just dismiss it. And so, yes, I agree. I mean, look, this is what I trained for years to do. I want to create this knowledge, and I want it to be worth it. I agree with you. And so, but it takes more than just the numbers to convince many people.
Yes.
But it's hard to disagree with your statement. It's absolutely true. You've got to show the overall societal value of keeping people healthy. Smart.
Yes. Well, thank you so much, Dr. Pruitt. I think that's a great segue into our next speaker, Mr. Scott Darius. So take it away.
Awesome. Thank you all for having me. What a pleasure to be here and to follow Dr. Zach. What a just eye-opening presentation. And for someone like me who's in this all the time, I learned so much just like, sitting here for the last little bit. And it's actually the perfect setup, I think, for the rest of this presentation, in that we're going to hit on a lot of the themes that Dr. Zach pulled out. And I guess the presentation ahead of this one really gives us some context as to like where the different metrics I'll hit on fit in, some of the policy changes that we're talking about. I think it's really helpful to get a full understanding on how these things really impact social determinants. But just quickly, for those of you who are new to us and me at Florida Voices for Health, I'm the executive director there. And like you heard, our mission is to increase access to care for low income and moderate income Floridians. But we really believe in doing that work in coalition. There's just so much work to be done that no one person or entity is ever going to get us across that finish line. So we're just blessed to have the wide coalition of partners that we do, who are all super engaged on getting this work done. We focus on issues including strengthening Florida Medicaid. That includes both fighting for expansion, but also pushing back on some of the cuts that we see suggested every legislative session. Oral health, improving access to oral health is high on our priority list, and protecting Florida consumers. There are a lot of problems with private insurance access, even on public plans, and we just stand there ready to hear those issues and to do advocacy on either a legislative level or administrative, state or local. But my goal for today, really through the lens of health equity, is to leave you with a high-level sense of where we are in healthcare in Florida and what opportunities really lie ahead of us. We'll start by looking at a couple of different factors that help to paint a picture of where we are here in Florida. And this is where we'll see a lot of what Dr. Zach shared echoed. And then we'll take a look at legislative session. how things played out, and some of the opportunities that we missed. And then finally, we'll share a little bit about what's ahead of us when it comes to the needs of our state and our continued advocacy. So as we begin to look at the landscape, the healthcare landscape here, I think coverage and access probably as good of a place to start as any. Coming off of the pandemic, I think we're only really beginning to grasp the impact that the last few months has had. It's probably fair to say that the pandemic really uncovered it uncovered the truth of how fragile of a system we had to begin with. Like just how many people were already living paycheck to paycheck, just how taxed our system is in taking care of these folks, and how far we have to go to really have a comprehensive system that's there the next time we have a public emergency, but even in like normal times, day to day, that we're meeting the needs of as many people as possible without folks falling through all of the cracks, really the opportunities for cracks that we saw laid out in the social determinants sheet or graphic. But yeah, really the last few months, I think just opened our eyes to just how vulnerable so many Floridians find themselves. Even before COVID, Florida had the 4th highest number of uninsured people in the country. And that's despite leading the nation in enrollment. Almost every year the ACA has been in existence. Every year the marketplace has been around. And I just think it's a really good indicator of the level of need there is in the state in terms of access to care. And in the years since, and we'll see that post-pandemic, things have only gotten a little worse. When it comes to oral health access, we know that more than 5 million Floridians are living in what the federal government designates as dental provider shortage areas, which means people living in places where they have limited or no access to dental care. And then even among children, where we made years of dramatic improvement in our insurance rates of kids, over the last few years, since 2016, we've unfortunately seen that number tick up. And it's about 55,000 kids who have lost coverage, I think, since 2016. So really something that we're keeping our eye on as we continue to do this advocacy. But then there's the impact that COVID has had on the safety net system and Florida's budget. Going into this legislative session, Florida officials and economists were projecting significant budget shortfalls. But in the face of an economic downturn like we saw in 2008, Medicaid really stepped in to get a lot of Floridians covered. And despite our unreasonably low eligibility thresholds, which I'll dive into in a second, so despite that, we still had nearly 700,000 Floridians who enrolled in Medicaid since the pandemic started. And it's that influx of enrollment that was really a large part of the anticipated budget deficit that we had coming into this session. I'll say that most of that was covered with federal funds, and the federal funds conversation is one we'll have a couple of times through this presentation. But finally, we know that Florida hospitals, which are already under great strain, still found themselves under threat this last legislative session. There were a couple of weeks there where it looked like significant cuts were coming, including a House proposal that had $500 million in cuts to safety net hospitals. Again, not something that ultimately happened, and a lot of that was covered with federal funds, but still, it's just kind of a recurring conversation we have every year, whether we're in a downturn or not. But diving a little deeper into the number of uninsured Floridians, we know that there's a category of folks who have no options for care whatsoever. And that's because they earn too much for Medicaid, or they earn too little to qualify for tax credits on the marketplace, which start at 100% of the poverty level, but we'll get into that too. And we'll go into this for sure, but that's who Medicaid expansion was intended to help, the people who fall into that coverage gap. Before the pandemic, I think the estimates were that we had nearly 900,000 people who would have been eligible for expansion. But in the last few months, we actually saw CMS, so the Center for Medicare and Medicaid Services, they released their estimate. And for Florida, it was 1.1 million people who would benefit from expansion. Now, even though we patched up this last little box, even though we patched up the safety net system with general funds from the latest COVID relief bill, We also left an additional $3 billion on the table that would have covered both the influx of people who signed up over the last few months, but also the people who were left out from Medicaid expansion. So again, just kind of going through some helpful metrics, looking at outcomes, which Dr. Zach talked about quite a bit. We can see that in overall categories like premature deaths, poor physical and health days, low birth rates, we're as a state doing slightly less than the national, or slightly worse than the national average. But it's also worth kind of pointing out the variation that exists between the counties themselves. You can see our low numbers and our high numbers, and there's just like a great variation between those things. Clearly, there are parts of the state that are doing worse than others. Now, this slide actually just shows, again, that variation among the counties. And you can see that a lot of Florida's rural counties, especially up in the north central part of the state, are faring a lot worse than others. But I caution folks, because I think all of us, being where we are in the state, myself being from Miami-Dade County, comparatively, it's doing pretty well. But I think we all know that there are parts within each county that there are communities that are doing much worse than, everyone else in that county, much less everyone else in the state. So it's not to say that, hey, this county's doing good, like, let's move on. I think it encourages even a more local approach to addressing some of these issues. This slide is just kind of the numbers behind the images that were on the last slide, but I included it mostly so you have when we send these slides around. Another important factor to consider from a consumer perspective, certainly, is affordability. Now, this is a whole issue on its own, and it's consistently the #1 barrier to care that we encounter in the course of our work, which is at the heart of it is collecting stories from consumers. In 2019, we worked with the Autarm Institute to execute a survey that assessed affordability concerns among Floridians. The top line from the report that we put out was that 55% of the people who responded had one or more affordability burdens. Now, what was unique about this report was that we looked at affordability. It wasn't, I guess what we used to define affordability was a little broader, in that we considered all of the ways that affordability plays out in people's lives. So whether that's people having to cut pills, having to skip bill payments, being contacted by debt collectors, and all of the other ways that feeling the financial pressure of a healthcare related episode impacts people's lives. Now, but Florida is a pretty large and diverse state, so it's a worthy exercise to also look at, to kind of slice this conversation by looking at different populations. In rural Florida, for instance, we see that COVID has taken its toll. There's a Jacksonville University report that saw the highest death rates for COVID were primarily in rural parts of the state. And that same report found that a lot of, I guess, the high death rates that were associated with those COVID cases were directly tied to poverty and access to care. Another revealing metric, I think, when looking at rural communities is access to, well, actually just the availability of primary care physicians. The Florida average is about 1 for every 1,200 people, but in some rural counties, we see a much greater disparity. And then additionally, looking at uninsured rates in rural areas, on average, it's 13% higher than in metro areas around the state. The average uninsured rate across Florida's rural communities is 37%, compared to 24% in rural in some metro areas. But then there are some other rural communities like Columbia and Jackson counties where the uninsured rate is as high as 42%. Now, finally, again, looking at just where hospitals are here, we know rural hospitals are carrying the brunt of the load when it's, especially when it comes to seeing uninsured patients. There have been 7 hospitals, rural hospitals, to close over the last, well, since 2005. Of those 7, 3 of them actually closed last year: Shands Stark Regional, Shands Lakeshore, and Shands Live Oak. And it was working with some of our partners at the Rural Health Partnership that I learned that it was like 70% of the people in these areas actually relied on these places as their primary care location. So you can imagine that when these shut down, and some of them went to kind of emergency only, to an emergency room only status, it really limited the availability of a primary care physician for a lot of people in rural parts of the state. But as a nation, we're also in a really important moment for racial justice. As a health advocacy organization, we see expanding access to healthcare as being critical to addressing the disparities that just exist across communities of color. When it comes to those disparities, more than 30% of the direct medical costs faced by communities of color are directly tied to health inequities. Fortunately, though, we've seen in Medicaid expansion states that the differences in coverage between racial and ethnic groups narrows significantly. In Florida, when we talk about what's at stake with Medicaid expansion, about half of the people who would be eligible for coverage come from communities of color. 29% of those are Hispanic and 22% of them are Black Americans. And finally, just wanted to quickly highlight where we are with oral health, just because it's a big part of our work. Last year, we got a small glimpse of how things played out through the pandemic by hosting a series of roundtable conversations with oral health stakeholders from across the state. Primarily featured dental professionals, administrators, some advocates, people from some of the FQHCs and the free and charitable clinics. Through those conversations, we found that among the most significant barriers to oral health is the affordability and lack of providers, like we've talked about. Specific to the impacts of COVID, we've seen increased costs for providers and an increase in the number of uninsured that the safety net is left to deal with. So again, just more things that we have to deal with coming out on the other side of the pandemic. But it's really in this general landscape that we arrived at the 2021 legislative session that happened this past March. There were a couple of wins for health equity and a lot of missed opportunities. The biggest win was the extension of the postpartum coverage for women, for pregnant women who qualify for Medicaid. Before this session, women who were eligible for Medicaid because of their pregnancies lost their coverage 60 days after the pregnancy ended. However, we all know, and I say we all lightly, right? Some of us know more than others, that the hard work of pregnancy and motherhood doesn't fade away after 2 months. And really, that's something we haven't grappled with as a state, as a country, as a society, really, because somehow we remain the only developed country with maternal mortality and morbidity on the rise. And that, like Dr. Zach mentioned, really shouldn't happen here. There were 2 bills filed this year that would have done this extension, but it was picked up by the House Speaker, Chris Sprouse, and it was actually passed as a final part of the budget. So just something we're really excited to see. Obviously, it doesn't do everything we'd like. But another major win for healthcare, health access, and health equity was this bill from Senator Rouson and Representative Camilla Brown that really tried to address the existing disparities that I think our experience with COVID the last few months exposed more broadly. Just high-level stats, right? We know coming out of COVID, 1 in every 1,000 Black Americans died of COVID-19 in 2000. In 2020, Black Americans were 1.4 times more likely to be infected with COVID-19 and 2.8 times more likely to die from it. And for non-Hispanic Black Americans, they were 5 times more likely to suffer infant mortality than white Americans. So we just, again, I think kind of repeating what we already know, and that's disparities exist. This bill tried to make the state and local departments of health more intentional about equity by establishing a minority health liaison in each county. The liaisons would be responsible for making sure that the counties are implementing existing health equity policies, but also exploring opportunities for new ones. Now, once these individuals are established, I think for us as advocates or for people working, whether we're providers or working with community groups, I think those folks could be really helpful to us to start building relationships as we try to address the problems that we see in our own local communities. So just, I think, a really good avenue for some of the advocacy we all hope to do down the road. Now, there were a couple of other bills passed this legislative session that in some way impact health access, but I won't linger on them too long. There was Senate Bill 348, which was really intended to help seniors enrolled in Medicare who require emergency transportation. We heard how crucial transportation is and the social isolation. If I got nothing else from this presentation, it's that the next time I'm looking for someone to listen to me talk, I'm just gonna schedule a doctor's appointment. Now, Medicaid, not Medicare, typically picks up the cost of emergency transportation, and this is for people enrolled in Medicare, but some of those ambulatory services weren't being covered, and this bill kind of made sure that the comprehensive universe of emergency services are covered by Medicaid for people who are on Medicare. The next bill we saw, we know that mental health is coming more and more into focus coming out of the pandemic. And while Senate Bill 1024 didn't do a whole lot to directly address access issues, it at least requires the Department of Financial Services and a couple of other government agencies to track complaints that people are making about access to mental health care on the health plans that they have. I think the hope and the opportunity for advocacy is that we can use this information to call for better policies, to see where the gaps in care exist, and to identify opportunities to strengthen the system. And then finally, this last bill, while not directly related to healthcare, I think just has major implications for all of our future efforts. SB 1890 limits the size of contributions to citizen ballot initiatives. And now the most anyone can give is $3,000 at a time. But if you stop to think about it, the greatest achievements we've made in equity as a state over the last few years have come almost exclusively through the ballot initiative process. That includes Amendment 4, which restored voting rights, and then the minimum wage amendment we saw pass in 2020. Clearly, us as Floridians have a history of kind of taking up these issues on our own, and this bill seems to stifle that. And now it threatens, I think, a lot of future initiatives, including the greatest opportunity we have to expand access to care, which is Medicaid expansion. Again, looking at session through a health equity lens, not passing expansion is the greatest missed opportunity we've had. For those of you who don't know, but I'm sure most of you have a sense of it, of just how restrictive Florida's Medicaid program is. First, you have to have a dependent child. If you don't qualify for care at all in this state. Now, if you do have a child, the most you can make is 31% of the federal poverty level. As an example, because I know that's just a random percentage, that means that the most of someone in a family of 3 can make and still qualify, that the most you can make in a year is $7,000. And if you can imagine feeding a family, taking care of a family on a 3-person family on $7,000 for the year, you are my hero. If you have a way to do that, I'm impressed. But that's where we find ourselves. And then there's a smaller category of people who are disabled or who have a disability who are also left out, who would benefit from Medicaid expansion. But in response to kind of this situation, there were 5 expansion bills filed this year. The only one that was really different was SJR 276, which wouldn't have immediately passed expansion, but it would have put the issue on the 2022 ballot. And then the other 4 pieces of legislation were actually pretty identical in that it was just a straight expansion of Medicaid. Unfortunately, none of them got a debate or a committee hearing, and the closest we actually got was 2 legislators filed amendments during the budget debate. Both were actually withdrawn before we actually got into it at all. Senator Tadeo was able to deliver kind of a passionate speech for it, but then immediately withdrew her amendment. So just another year in session without it going far. But still, if you'll do me the grace of allowing me just a second to harp on this point for a bit, because I just can't stress enough what Medicaid expansion would mean to the state, and especially as we're talking about health disparities. Unfortunately, one of the things we hear the most from legislators is this, from opponents of expansion, is the mischaracterization of the people who would benefit from it being in place. Opponents often cast this group as a bunch of able-bodied, non-working adults, and the underlying belief is that these people aren't deserving. So actually, to the earlier question about Do we have data to show, the financial impact and things like that? I'll point to that in the next slide. But unfortunately, so often what we run up against is just this underlying belief of who's deserving and, why we should go out of our way to give these folks care, even when it's nothing but a financial boon to the state. And the fact is that Medicaid primarily covers working Floridians and Floridians who are, if you want to say it this way, legitimately out of the workforce. So caregivers, students, people who have a disability themselves that, isn't, I guess, captured in a way that qualifies them for coverage. So that's to say that there are a lot of people who, this is really, it's working people we're talking about. It's directly impacts our workforce and is probably the best opportunity we have to strengthen it. Yeah, I'll move on. And actually, there's this list that I put here of the 10 lowest paying jobs in Florida. Obviously, they typically don't offer health insurance, but if we stop to think about the folks who we relied on the most over the last year and a half and how many of them appear on this list because we designated them essential workers, we'll see that there's a lot of overlap between the folks we relied on and the folks who don't have health insurance. But then finally, and unfortunately for legislators and decision makers, everything usually boils down to the fiscal impact. Maybe the only good thing to come from us being one of the last 12 states to expand is that we've seen the experiment play out in 38 other states. And we know that it saves us money. Watching other states, we know that there's an economic multiplier effect that brings billions of dollars into the economy. So to go beyond the larger point of here's the money we could save in the healthcare system, there's money we can add to just our overall economy, and that's clear. But then looking back at the direct financial impact, we know that Florida would save $200 million every year we have expansion in place. And that's mostly from kind of streamlining and condensing the hodgepodge system that we have. So right now we provide, a lot of emergency room care. We provide health services in prisons in kind of one-off settings. There's just a lot of money that's put into different programs to take care of kind of acute conditions or things immediately, but there's not that comprehensive care that keeps people healthy and stops them from coming back. And then on top of that, the American Rescue Plan that passed earlier this year added a 5% bump in the Medicaid's a matching program. So Florida's match rate would have had a 5% increase, which translates into an additional $3 billion for the state at a minimum. Some estimates had that up at $3.5 billion. And by the end of session, legislators said, no, thank you. They took a general pot of money that we got from the ARP, but even that general pot of money could have been used in other parts of the budget if we had expanded and taken the $3 billion to cover both the folks who have signed on in the last few months and the larger expansion population. And then, sorry about that. But then just other quickly missed opportunities in the fight for health equity was House Bill 899. I think so much of the work that we have to do in this space starts with just better understanding where the gaps are, what some of the issues across the system are. This bill would have helped us to do that by requiring Medicaid plans to actually disaggregate their data based on race, ethnicity, disability, and a couple of other metrics. Really would have helped us to gain, I think, some crucial insights into how we're serving this especially vulnerable population, because that's what we know of people who are enrolled in Medicaid. They're obviously low income and among the most vulnerable. And then at Florida Voices for Health, we really try to take on policies that reflect the stories that we hear from consumers. Oral health is at the top of that list. And right now for adults who are enrolled in Medicaid, we know how limited the benefit package is. So strengthening that is a big initiative of ours, and it was a bill that we saw filed this year in session, but got no play whatsoever. The same for dental therapy, which actually tries to address the dental shortage question, looking at the provider side of oral health. It would have created this mid-level provider somewhere between a dentist and a dental hygienist. They would have had to go through years of schooling And I know it's a controversial issue, but I think it's still something worth debating and looking at as we try to find solutions. And then just quickly, insulin price caps is another bill that we saw not looked at all this year. We know that communities of color face higher rates of diabetes, obesity, stroke, heart disease, and other chronic diseases, but diabetes especially, the risk of being diagnosed is 77% higher for African Americans and 66% higher for Hispanic Americans. So something like this would have directly addressed, just by kind of addressing the cost of drugs, particularly insulin, would have directly impacted some of the health disparities that we see, and especially the affordability issue. There were a couple of other bills that passed this session. There was HB1, which I know a lot of folks have come across, the anti-riot bill. I think the impact of this bill is clear, and that it would have, it may affect just how safe people feel in their own communities, and ultimately have a chilling effect on, civic engagement in efforts to advance equity. And then another bill likely to impact civic engagement is SB 90, which introduces changes to the voting system, including the use of drop boxes. Now they can only be used during voting hours instead of 24/7, and voters have to request vote by mail ballots every election cycle instead of every 2 cycles. There were actually some encouraging changes made to law enforcement, where they changed kind of some of the training that needed to be done, and there was an emphasis on making sure that deadly force is used only in specific scenarios. So actually a positive change that, again, maybe hopefully has a positive impact on how safe people feel in their own communities. And then a taxation bill, which actually just had a really, there's a lot we could do to address housing. We know that affordable housing is an issue. And it's a small first step, but it at least tries to address the supply side of the issue by expanding the tax credits for entities to build affordable housing. But I'll leave you just with this last part, which are ways to engage in the work moving forward. Beyond supporting many of the same pieces of legislation in the upcoming session, our plan for the future is to focus on building the infrastructure we need to do lasting advocacy here in Florida. The need is clear, right? As we've talked about how legislators continue to not address many of the direct concerns of Floridians. Instead, we're finding that we're losing legislators to misinformation, bias, and oftentimes I'm willing to chalk it up to just a genuine lack of understanding about the needs that people have, the policy opportunities, and exactly who benefits from these things. Us at Florida Voices, we're trying to counter this by continuing to capture and elevate the personal stories of Floridians, but also empowering them to share their own stories. And we're lucky enough to have partners who do the hard data research, so Florida Policy Institute, and we really couple those things, the numbers along with the narratives of the people who are in these impacted communities. And it's really that work that we hope to engage you all in your various roles across your different types of organizations. I think you can all be a part of the important work to shift the public narrative, primarily through story collection. A large part of how we do our story collection work, we have 2 full-time story bankers who work with consumers, talk to them, capture their story, and also try to connect them to resources, because we know we don't see it as a transactional thing, but really kind of a relationship building opportunity. So you all have chances or the opportunity to partner with us to refer stories over. We try to capture those. We put together some outcomes like the written narratives, short promotional videos, infographics that we also share with you all as partners, really to highlight the work that you're doing in helping to strengthen our communities. If you want to learn more about those partnerships, it'll be linked in the presentation, this one-pager, that just has a little bit of background on how we do the work and what the opportunity to partner looks like. If you're interested in getting involved in the Medicaid expansion campaign, that's growing every day. It's a massive statewide fight that we kind of need everyone's hands in. There are opportunities to help with community education and outreach, the story collection, which I mentioned, but even the signature collection work that's being headed up by Florida Decides Healthcare. You can learn more about the overall campaign by visiting healthcare4fl.org. And then lastly, if you're interested in any of the oral health work, there's what's called OPEN, so the Oral Health Progress and Equity Network, and then the Florida kind of chapter of that. And it's, just oral health stakeholders working to advance policy. Right now, we're focused on the adult dental benefit, but that's an opportunity to engage with us. And then lastly, if you just want to get involved with our overall coalition, Florida Voices for Health, you can just shoot me an email or visit healthyfla.org and we'll get you plugged in. But thanks for having me. This is a really great opportunity.
Thank you so much, Scott. We have a couple of questions in a couple of minutes. So first, if you could just give a quick explanation as to the difference between health outcomes and health factors within the county health rankings, and kind of explain if a county has a great difference in the ranking of the outcomes and the factors, what does that mean?
So I think, Dr. Zach can help me out here a little bit too. The outcomes look specifically at a couple of key things, right? Like when you're, final kind of measurements. So how many people died prematurely, how many people have good or bad health, how many people have poor physical days and whatnot. Whereas the factors are the things that lead to those outcomes, right? So whether it's smoking, the rates of smoking in some of these communities, access, like the availability of providers, things like that would be the different factors. In terms of what the actual numbers mean, if you're let's say, right, looking at this map, these are relative to each other, right? So this is just ranking Florida counties from 1 through 67 and doesn't say anything about what that means in the context of like a national picture. But still, I caution folks because let's say, like I know Miami-Dade, again, as an example, is in the top quartile here, right? But we know that there's Liberty City, we know that there's Little Haiti, we know that there's Hialeah, smaller neighborhoods and communities within those counties that just aren't doing as well as the county as a whole. So yeah, it's a good first step, but also worth looking a little deeper if you're someone who's working on a more local level.
Great, thank you. One more question. And Dave Rogoff shares, this financial impact is great. Also, historically, the state has been unwilling to pass on federal sharing to counties that do have safety net plans, except maybe LIP. Any chance that this could happen? Years ago, I was actually told by state that if they did this and the county decided not to continue the arrangement, the state would have to pick up the cost.
So if the question is, I think I missed the first part. If the question is how likely are we to kind of move towards a system where we're just relying on local governments to provide that care, to provide coverage, I'll say that there's actually been a lot of debate about that in the last few weeks. I believe a representative from Texas, Doggett, filed a bill that would go about Medicaid expansion that way. I worry because so much of what we've seen in the last few sessions is kind of this usurping, how do I put this, of like local control from Tallahassee across like a bunch of issues, whether it's smoking or plastic bags, all the kind of like local policies that folks are taking up. We're seeing some of that preempted by what's happening at the state. And I think it's a lot of speculation right now as to how some of that might play out if we went with a more local approach to expand care.
Thank you. At this time, I want to thank you both, Scott and Dr. Pruitt, for your incredible knowledge. And wow, I know I learned a lot today. So thank you so much for taking the time to be part of this. I also want to thank Baycare once again for their support in this important initiative. We are about halfway through. We have 6 total sessions and 3 down and 3 to go. So for those of you who are participating, you will receive the recording and resources probably early next week. And those who have registered. Anyone who registered will receive all of those materials. Our next session is session number 4, Inequitable Economic Determinants of Health, and that will take place Friday, July 9th. From 12 to 1:30. I know that many of those that are registered and participating are registered for all. I encourage you, if you have not registered for the next 3 sessions, please go ahead and do so. There is a waiting list. And again, anyone who's on the registration will be able to receive the recordings and all of the resources as well. If you know that you're not going to be able to participate live, please do let me know so that I can offer your spot for live participation to the next person in line. I also want to just ask you to please complete the follow-up survey. It will also be sent with the materials early next week and will pop up when we are finished here. Thank you all for participating, and I look forward to seeing you next month. Thank you so much. Have a good one.